This is QD Clinic. I'm Jack Cush from RheumNow.com. QD Clinic is brought to you by RheumNow.live. So this case is called 7 DMARDs and Counting. A CCP positive rheumatoid arthritis patient comes to you with many swollen and tender joints, 11 tender, 9 swollen, a CDI of 32. It's the same as rapid, same as a gas. The patient had previously been treated with methotrexate, etanercept, adalimumab, abatacept, baricitinib, tofacitinib, sarilumab, Kevzara, Otezla, Primilast. Right now, the patient's on a Primilast, sarilumab, and 10 milligrams of prednisone is doing poor. Why is the patient on Otezla? Someone thought the patient might have psoriatic arthritis. This is a strongly CCP positive individual. And the question is, what would you do next? This patient had been doing really, really well for a long time on methotrexate and etanercept, like 7, 8, 9 years, and then boom, out of nowhere, a secondary loss of response. So this is like 7 or 8 DMARDs in, and what are you going to do next? What is your next choice? What do you offer the patient? Here are the offerings, and we have to go with drugs the patient hasn't seen yet. How about sulfasalazine with anakinra, number 1? How about number 2, leflunomide plus rituximab? Number 3, methotrexate plus certolizumab. 4, triple DMARD therapy. 5, some other concoction that only you are known for. Well, the good news is we've put this out to a Twitter poll, and we asked rheumatologists on Twitter, got back 231 responses in 24 hours, and the number 1 answer by 78% of your peers was, that's right, number 2, leflunomide plus rituximab. What do you think was second most common? Methotrexate plus certolizumab at 11%. So that locks up 89% of the choices. Only 8% would do a triple DMARD, and only 2.6% have any faith in anakinra. By the way, anakinra is FDA approved and works in 40% of people the same way etanercept works. But nonetheless, all of you think it's not a good drug, but it is a good drug. It just happens to require to be given once daily. So what's the wrap on rituximab? You put it last on your list because you've got so many other choices. But realize there's a lot of data about rituximab working great as the second biologic. There's a lot of data about rituximab working great as the first biologic. To put any biologic 9th in the list really means that you're stacking the odds against it, right? I mean, so someone who fails multiple biologics is going to continue to fail future biologics or future therapies because there's probably much more involved here than a unique biology that you haven't quite hit upon yet. So my point is, don't wait until the 9th biologic or the 9th DMARD to use rituximab. I think it merits a consideration soon after you fail a TNF inhibitor, or maybe right after they fail at methotrexate. Of course, everybody's afraid of a 1 in 30,000 risk of PML, which again, that's like chance of getting hit by lightning or getting married to a donkey. You know, I don't know that either of those are possible or even legal. So this case is a tough case. We'll see what happens when the patient comes back on her next combination of therapy. But if you chose rituximab plus leflunomide, you're falling in line with over 80% of your peers. That's it for this edition. Go to RheumNow.live to register.